Good morning to everybody today. Thank you to the organizers for inviting me. So as mentioned, the organizers asked me to speak on renal and hematologic complications of pregnancy. And I'm going to use my disclosure slide to stretch a little bit because this is an enormous topic that I'm going to try and shoehorn into my 20-minute time allocation. When I was packing to come here about a week ago, we took the train, and so I took a carry-on bag, and I felt very similar trying to pack my carry-on that I did also trying to edit down these slides. But I am going to try and take with each of these conditions and the topics we talk about an overarching approach, which is what I do when I'm looking at any medical condition in pregnancy, which is number one, figuring out how to identify the issue, or in a lot of cases, generate a differential diagnosis. And number two, probably most important, is understanding the physiology of pregnancy, because a lot of things that look abnormal, in fact, are normal, and a lot of things that might look normal out of pregnancy are not. And finally, I'm going to focus on identifying groups of risk. And so if that's a lot to go through in 20 minutes, I have hidden little keys in the slides that I think are the most important take-home messages if you're like me and can only remember about 2 or 3 things from each talk. So we're going to start off with the kidneys, and whenever I think about kidneys and the pregnancy, this is sort of the image that comes to mind, because they are a very hardworking set of organs, particularly in pregnancy, and there are a lot of physiological changes that are really important to know about, particularly when they come to one of the topics we're going to be talking about, which is acute kidney injury and causes. So there are huge shifts that start in the renal hemodynamics as early, in fact, as 4 to 6 weeks gestation. So it isn't just about blood volume, which most of us know increases particularly along the latter half of the pregnancy, but and reaches up to 80% increased blood flow by around 34 weeks. But the kidneys actually swell about 1 centimeter increase in diameter, and there's an increase in glomerular membrane pore size. What impact does this have? Well, it changes the amount of protein that's released by the kidneys into the urine, and we see pre-pregnancy it's around 100 milligrams a day, and it goes up to 180 to 200 milligrams by the 3rd trimester, and that can be even higher in twin pregnancies. That is why the cutoff when we're diagnosing preeclampsia is in fact higher at 0.3 milligrams per day to account for the higher amount that is occurring in normal pregnancies. What this also means is that this is a beautiful time for occult or pre-existing proteinuria to manifest for the first time, because it's like an iceberg and it rises to the surface with the underlying physiology driving it. The glomerular filtration rate also increases, and again, it's not just blood volume, because we see this change as early as 4 to 6 weeks gestation, but it truly peaks by around the 2nd trimester. There's physiologic hyperfiltration, and it has a notable effect on serum creatinine levels, and I'll show you in the next slide. There's a beautiful 10 to 15 point drop, and why that's important for us to know is, in fact, eGFR is not validated for use in pregnancy, so we really use the serum creatinine levels when we're trying to diagnose any underlying renal disease or any new renal disease, either pre-existing that is manifested or de novo in pregnancy related to pregnancy complications. So this is just a nice slide of a lot of pre-pregnancy and pregnancy measurements of creatinines. And these were in healthy, uncomplicated pregnancies. And you can see here the blue line on the bottom is the 50th centile of a normal pregnancy value, and the top line in black is a 95th percentile. So in every single one of these cases, and again, these were pregnancies that had no underlying renal disease, no poor outcomes, you can see that at the start of the pregnancy, if you're sitting at a creatinine of 60, you're going to drop around 10 to 15 points. That starts as early as 4 to 6 weeks, again, in the first trimester, and reaches a nadir by around 18 to 22 weeks before rising back up again to the pre-pregnancy baseline closer to and right at the time of delivery. So why this is important, and you'll notice the first little gold key here, is that there are red flags that are really important to know, and they're not the red that shows up on, at least it does on my abnormal values, because the creatinine range in pregnancy is lower because of the EGFR. So a creatinine, in fact, you can see on this, nowhere in a normal pregnancy is there a creatinine measurement that goes above 77. And the other thing I wanted to flag when we're talking about the first trimester is in patients with chronic kidney disease, we look at that first trimester drop to see how they're physiologically tolerating the pregnancy. So if I have somebody who's going into pregnancy with known chronic kidney disease and their creatinine is 110 or 120, I'm looking for that drop in the first trimester because it shows me potentially how they're tolerating the changes even that early on. So moving forward then to acute kidney injury during pregnancy, and this is a bit of a difficult one when I was looking up through what's the incidence, and the reason is because we actually don't, as many things in pregnancy, have a universal criteria because all of our usual criteria are not validated in pregnancy. But on average, it probably impacts around 1 to 2% of all pregnancies, and there is a decrease in certain causes like hemorrhage and sepsis, but rising rates of others because we have more women going into pregnancy at higher ages with more comorbidities, and so this is becoming more common because of these other rising rates. And why this is important is because it is associated with higher rates of morbidity, and it's not just morbidity for the mom and healthcare utilization, but also for the fetus. So we know that in cases of acute kidney injury, there's 4 to 5 times risk of intrauterine growth restriction, preterm delivery, low birth weight, and neonatology consults and ICU stays. Practically speaking, how do I diagnose acute kidney injury in pregnancy? It can be challenging at times because some of the pregnancy-related conditions, such as preeclampsia, move very quickly. But really, I go back to those normal creatinine values in pregnancy, or I look for a doubling in their baseline. If I have any baseline measurements, I look at urine output, what's going on clinically, and the usual laboratory and imaging tools that we would use outside of this. Next, we're going to move on. In the context of acute kidney injury, I'm going to just take a step back and show you how I approach and create a pregnancy differential. And so this can be applied for either a symptom, so somebody coming in with a headache, chest pain, shortness of breath, or a finding like you get an elevated creatinine in the 80s and 90s, and you have to think, okay, this is new. How do I approach my acute kidney injury? And I break it up into 2 groups. Pregnancy related, which is this a physiologic condition of pregnancy, or is this something pathologic? Or is this pregnancy unrelated, in that it is a condition that could happen anytime outside of pregnancy, but it has been exacerbated by the physiology of pregnancy itself, or it just randomly showed up, which can also happen. So if we use acute kidney injury here, this actually gets a little bit easier because we know there's no physiologic cause of acute kidney injury in pregnancy, so everything we're looking at is on the pathologic side. And the pregnancy unrelated side, you all know this already. This is what we do day in, day out when we're not looking at after pregnant patients, so we apply the same principles. In this case, I sat down and created a list of all the possible pregnancy-related causes of acute kidney injury that we would not see otherwise, outside of pregnancy. But again, it can be broken down into the usual approach, which is pre-renal, renal, and post-renal. I have included a few things on this list, and I've put the stars on there, both infection, so pyelonephritis, and then our usual TMAs, so TTP, complement-mediated HUS, DIC, and those in fact are actually not pregnancy related. They're physiology of pregnancy exacerbated, but they often come up on differentials when you're being asked to assess patients with atypical preeclampsia or acute kidney injury, other findings. This is the other way you can look at these conditions, is what's the etiology by gestational age. So we know that physiology impacts when certain conditions come up. And in the case of the kidney, we can use that understanding of the physiology as well as conditions that are more common at certain times in the pregnancy. But really, what I want to spend a little bit of time talking about is the most common cause of acute kidney injury, and that is preeclampsia. So preeclampsia is a disease of many theories, and every year we get closer and closer to sort of unraveling all the contributing factors, but we're still not there yet, and this has been a condition that's occurred essentially since the dawn of time. We only really identified it in the 1700s, but the best way to explain it for internists and medical specialists is this is a heterogeneous multi-system obstetric disorder that affects the placenta, mother, and/or fetus, causing endothelial activation, inflammation, capillary leak. And so to think about it, preeclampsia is ultimately a disease of the endothelium, and that is how it manifests the bulk of its symptoms. The definition is new onset or worsening hypertension with evidence of proteinuria, or other evidence of end organ dysfunction at or after 20 weeks gestation. Ultimately, preeclampsia is a progressive condition. It's fulminating, and it will only abate with delivery of the placenta. There are lots of signs and symptoms, so it's a disease of theories and a disease of symptoms. And I'm not going to go through all of them, but if you are interested in learning more about preeclampsia, I will direct you to the McMaster textbook of internal medicine, which has a really nice summary chapter with all the symptoms, underlying pathophysiology, and investigations that we do. Because I do want to go back to the kidney, because I know, as was said in the introduction, the kidneys are very important, and they are particularly important when it comes to our understanding of preeclampsia, because in fact, it was the albuminuria that was detected in the 1800s in women with these symptoms that actually led a lot of the initial hypothesizing around what exactly is going on. And preeclampsia and the kidney is a fascinating subject, but I will just sort of summarize by saying, number one, you can look at the two organs, and they actually look very similar. The placenta, which we think the inciting event occurs to start the cascade that ultimately ends in the symptoms and findings of preeclampsia, and the kidney itself. And we know there's a bidirectional relationship with shared risk factors. From the placenta to the kidney, we can see, and this is, I can't have a nephrologist in the room without putting up a slide around the characteristic pathology findings of glomerular endotheliosis. But we don't do a lot of biopsies now because practically speaking, we know that around 85 to 90% of patients who have preeclampsia will have proteinuria. And about 15% of these cases will have acute kidney injury. And when we look at the kidneys and what's going on, one of the indications for maternal delivery, the disease has progressed to a point where we do not think it is in the safety of mom or baby to go further, is either a creatinine greater than 110, a doubling of the creatinine, oliguria, and or anuria. Hopefully it doesn't come to that, but it can progress quite rapidly, but not the degree of proteinuria. So that in and of itself has not been associated with maternal and obstetrical morbidity, but has been taken out of the guidelines in the last few years. It's also important to know that the risk of future progression to chronic kidney disease after a previous episode of preeclampsia is around 2 to 4-fold, with divergence as visible as soon as 1 to 5 years postpartum. So preeclampsia is not a condition that is cured by delivery. The catastrophic effects are abated by removal of the placenta, but it can have very long-lasting effects to the mother and increase the risk, particularly with cardiovascular and cardiorenal metabolic diseases in future. We also know that pregnancy is a precious time to diagnose chronic kidney disease that has previously been occult. And in some studies, the prevalence of previously undiagnosed kidney disease in patients who experience preeclampsia is up to 20% compared to around 3 to 4% in a baseline comparative population. What about in patients with known chronic kidney disease? So they've actually had the diagnosis made before pregnancy. One of the key points to know, and this is from a fairly recent study, it was an Ontario, Canada cohort of about 40,000 patients, which in the pregnancy literature is a large study, and it looked at what the risk factors were and how to stratify patients with pre-existing chronic kidney disease in terms of either maternal severe morbidity during pregnancy or obstetric outcomes such as preterm delivery, preeclampsia, and low birth weight. And what they found was that the real risk markedly rose with a preconception eGFR less than 60 and or higher levels of preconception proteinuria in the moderate to severe range. So why am I telling you this if you're not a nephrologist? Because in this study, patients who had an eGFR between 45 to 60, less than 30% of them had seen a nephrologist in the 2 years coming up to pregnancy. But on average, I think they had 4 visits a year, every single one of them with either a primary care physician or an internal medicine specialist. So this group of patients, it's important to know who they are going into pregnancy because they need preconception counseling. This is a higher risk group of patients. The 2 take-home messages here, besides the patients, if you do catch them before pregnancy, which are that higher risk group in terms of obstetric and maternal outcomes, but also that only about 20 to 30% of patients who have experienced preeclampsia actually have documentation of particularly proteinuria resolution. And so that is those patients that have persistent proteinuria or have persistent mild impairment in chronic kidney disease, they all need to have it followed until it's done, usually within the first weeks, but it can take up until 6 months to a year postpartum to make sure that you take that opportunity to diagnose and catch any underlying chronic kidney disease. Moving forward now, I'm going to switch tacks quickly and talk about some of the hematologic complications. And here is where I had to be quite judicious, and the kidneys won out in terms of timing allocation, but I'm going to talk about the 2 most common conditions that you'll see from a hematologic point of view, and that is number 1, thrombocytopenia, and number 2, anemia, particularly iron deficiency anemia. So what happens in normal physiology? We know that platelet counts in normal pregnancies can drop around 17 to 20%, and you can see the distribution with patients who are not pregnant in the blue, first trimester and delivery. So almost everybody has a chunk over in terms of the drop in their platelet counts, but the majority are still, they're not hitting our clinical awareness because the majority of them are still over 150. Anytime you see a patient with a platelet count in pregnancy less than 100, it's really important to start making sure that you've thought through alternative etiologies, because that, in fact, in this study of normal platelet counts occurred in less than 1% of all uncomplicated pregnancies. It's also important to know that any new onset or rapidly worsening thrombocytopenia after 20 weeks gestation should always prompt evaluation for preeclampsia because it can be one of the first findings. So going back again to how do we approach our pregnancy differential, we can use the same method applied here to approach thrombocytopenia. So if we break it down into pregnancy-related, we have physiologic, which we have gestational thrombocytopenia, and we have pathologic, which is predominantly preeclampsia and/or HELLP syndrome. Pregnancy unrelated, the physiologically exacerbated conditions could be things like TTP, HUS, DIC, and you know, there's some thought that patients present more frequently with ITP, and there may be an additional immunologic burden that brings that to the forefront. Then you have all of your usual list of things you know and you consider when you're going through the differential for thrombocytopenia. It's also very important to identify, is this an isolated laboratory finding, or is it not isolated or with systemic features? Speaking very briefly about gestational thrombocytopenia, because this is the most common, affecting 10% of all pregnancies, and in fact here on the pie chart, around 75% of all thrombocytopenia in pregnancy is gestational. The key thing here is that this occurs gradually, usually late to second, third trimester, not in the first trimester, is mild. It's usually above 100, but we can occasionally see cases where it's as low as into the 70s to 80s. It is isolated, no other cell lines, no laboratory abnormalities, no systemic symptoms. You want to do your preeclampsia assessment based on that slide I put up earlier. And the other two things that can sometimes be helpful is if they've had a previous affected pregnancy. Usually we expect it to jump up quite quickly in the postpartum period around the first 2 to 3 weeks, and that they shouldn't have any affected fetuses with thrombocytopenia, because that raises the suspicion that it's actually ITP. HELLP syndrome is one time where I find internists and internal medicine specialists of all types, particularly GI and hematology, can get engaged, because in 10 to 15% of patients this occurs with no hypertension. We are learning more and more about this syndrome, and that likely it is related to certain angiogenic and inflammatory markers that are being released that are causing a dysregulated activation of the maternal alternative complement pathway. Getting into the zebras, I've just put down, in case you ever run into one of these patients where the obstetricians are saying, this doesn't look like preeclampsia, why is there thrombocytopenia, or you know, what's going on here? I've put some tips and tricks around some of the conditions that can overlap, and I've given you a much larger slide of the zebras that we see and how I personally differentiate between the two. But I want to end by not talking about zebras. I want to talk very briefly about anemia in pregnancy, and I'm going to focus on the pregnancy-related side. Pregnancy-related anemia, we all use the same WHO reference intervals, and these intervals are used, I think they're used here in Poland, they're used in Europe, North America, and they really frame what we view as normal versus abnormal. So you can see here, there is a hemoglobin generally in the first and second trimester cutoff of less than 100, and 10, postpartum, it's less than 100. But where did we get this information from? So WHO created these reference ranges in the 1970s, and this was a population that had high rates of iron deficiency anemia. And we know that there is some physiologic plasma volume expansion. We know that red blood cell production increases, and because the expansion is more than production, we get this dilutional anemia. But this is not the explanation for the differences in these hemoglobin cutoffs. And this is a beautiful article. I've put the citation here, talking from some Canadian colleagues around laboratory-based inequity in thrombosis and hemostasis. And really, what we have done is we have normalized a pathologic condition because it is common. And we know that the impact of iron deficiency anemia in pregnancy has a host of maternal and fetal poor outcomes, and it is something that is so easy to check and so easy to replace. And so the final slide I wanted to leave you with, and actually the most important thing of this entire talk, is that if you see a pregnant patient and you see them for whatever reason, if they have not had a ferritin done, they will have all had a hemoglobin in the first trimester, but if they've not had a ferritin, check it, because anemia is a late complication of iron deficiency, and up to 30 to 50% of patients will be iron deficient over the course of the pregnancy. And so with that one simple blood test and a replacement of whatever iron you want to use, that is probably the most impactful thing that you can do in terms of future health for these women. Thank you so much.